Appreciate it. Welcome, everybody. Thanks to all of you for taking time out of your life to join with me and with us this evening. Before I begin talking and giving my presentation, I think it's probably a good idea to just take some time and thank the entire student and resident committee for all the hard work they do, for inviting me to present tonight. And I'd especially like to thank the woman whose voice you just heard, Shannon Strader, Lauren Clark, Michelle Carnaccia, all of you for helping me put this lecture together for tonight. This evening, I'd like to talk with you about what I think are some rather important medical legal issues. And much of what we cover this evening will be relevant not just to patients with intellectual and developmental disabilities, or IDD, but I think it'll also be of benefit to you as you care for all of the patients that you're taking care of, no matter what their age, their race, their cultural background, or their intellectual capacity happens to be. But I think you'll all agree that this material is especially important when you're caring for a patient with IDD. Over the years, as I've taught a course in developmental dentistry at the University of Louisville School of Dentistry, and I've mentored students there for a long time. I've said many times to them that when you're caring for a patient with IDD, you really need to be at the top of your game, or you're probably going to miss something important. You need to take a thorough health history. You need to perform a systematic and a thorough intraoral examination and an extraoral examination. You need to review your clinical and your radiographic findings thoughtfully. You need to write a well thought out and a sequenced reality-based treatment plan. And you must be thoughtful and judicious and meticulous in attending to the medical and the legal issues that come to the fore as you care for what is really a very unique patient population. Before we get into the evening's material, I'd like to give you my contact information. I would be happy to hear from any of those of you who might want to reach out to me. I am the Chief Clinical Officer at the Lee Specialty Clinic, the building you see here in Louisville, Kentucky. My email address is henryhood@admed, that stands for Advantage Medical, henryhood@admed.us, and I invite any of you who wish to communicate to do so. Should mention at the outset that I have no financial interests or relationships to disclose with respect to this presentation. Very importantly, I want to make sure you know this, I'm a dentist, I'm not an attorney, and certainly none of the material contained in my lecture this evening should be construed as legal advice. Now, if you need legal advice in any arena for any of the patients that you're caring for, whether they're neurotypical patients or patients with intellectual disabilities, I think it's a really good idea to consult from time to time with a competent attorney. And in the longer term, I think it's an even better idea to establish a long-term relationship with an attorney who has expertise in what you're doing and an attorney that you trust. I've done that in my career. I speak practically every day with our clinic's attorney, and she's wonderful, and I've never regretted it. So I would encourage you folks to do the same. I consider myself fortunate to work at the Lee Specialty Clinic in Louisville, Kentucky. The Lee Specialty Clinic is an interdisciplinary outpatient program, and we serve about 1,100 adolescent and adult patients with intellectual and developmental disabilities from 60 counties in our Commonwealth. We focus exclusively on patients with IDD. And there at the clinic, I have access to experienced clinicians in multiple disciplines, including medicine, dentistry, psychiatry, psychology, behavior analysis, physical therapy, occupational therapy, speech and language pathology, endodontics, endocrinology, oral surgery, neurology, all of these disciplines and clinicians are there with me under one roof at my fingertips. And so I'm able to tap into this rich font of clinical expertise whenever I need to. But I realize that not every doctor, every clinician out there is as lucky as I am. Not everybody has access to these kinds of resources. And so as I was putting this material together, I wanted to develop this lecture for the general practice dentist who is out there, likely either in a solo practice or in a small group setting, but who is willing to accept adult patients with IDD into his or her practice. And to those of you who are willing to care for patients with intellectual and developmental disabilities, I thank you. I congratulate you for sure, and I hope that this material is of some value to you. I'd like to begin by describing as best I can the patient population, which will be the focus of this lecture, and really, as I understand it, is the focus of the other lectures that you've had and will have in this series, and that is the patient with an intellectual and developmental disabilities, or IDD. And let's start by defining what intellectual disability is. The American Association on Intellectual and Developmental Disabilities defines intellectual disability as a disability characterized by significant limitations in both intellectual functioning and adaptive behavior, which covers many everyday social and practical skills. Now, the AADMD also tells us that intellectual disability tends to originate or manifest before the age of 18. I don't think anybody would disagree with that. Now, my colleagues and I in the American Academy, we define intellectual disability in a somewhat more biomedical context. That's just kind of our arena. And so we assert that intellectual disability is typically featured as a complication associated with multiple neurodevelopmental disorders. And so you're probably asking now, what is a neurodevelopmental disorder? Well, a neurodevelopmental disorder is a medical disorder affecting the neurological system during that period of a person's life in which they experience rapid neurological development. And that is from the point of conception until early adulthood. That is the neurodevelopmental period, the period from conception to early adulthood. And it is this medical disorder, this neurodevelopmental disorder, which occurs during this period, that actually produces an injury to the brain. And that brain injury, in turn, produces what we call brain dysfunction. And the brain dysfunction manifests in the clinic in the form of multiple complications, and one of those complications is intellectual disability. And we'll talk a little bit more about those complications in a few moments. Here you see before you the four most common neurodevelopmental disorders. These are not the disorders that you read about in pathology class and never saw again after you got out of school. These are the disorders that, if you accept patients with IDD into your clinic or your office, these are the disorders that you're going to see and you're going to deal with. We have them listed here for us by the CDC in order of their incidence. Cerebral palsy, which is an acquired neurodevelopmental disorder. It can be either prenatal, perinatal, or postnatal. The injuries that produce cerebral palsy can happen in utero. They can happen around the time of birth. They can happen shortly after birth. But it is an acquired neurodevelopmental disorder that occurs in one of every 455 live births in this country. Then we have Down syndrome or trisomy 21, which is a non-inherited chromosomal neurodevelopmental disorder. I'm sure you know that the problem with this disorder is the extra genetic material at the chromosome 21 site. Well, this disorder occurs in 1 of every 700 live births. We then see fetal alcohol syndrome, what I think is a very, very sad syndrome. Fetal alcohol syndrome is obviously an acquired syndrome, and it's a 100% preventable neurodevelopmental disorder. And that disorder occurs in 1 of every 1,150 live births. And finally, we have Fragile X syndrome, a syndrome that many people have not heard of, but is really a quite common malady. It's an inherited chromosomal neurodevelopmental disorder that occurs in 1 of every 5,000 live births. Now, as those of us who take care of these folks, as we begin to care for patients with neurodevelopmental disorders, and especially early in our career, as we approach this patient population, we begin to work with them, it starts to dawn on us. It soon becomes apparent to many of us that the problems that these patients have tend to fall into certain very recognizable categories. By that I mean the problems that our patients with neurodevelopmental disorders present with tend to manifest clinically in 1 or more of several very, very distinct ways. Neurodevelopmental disorders will clinically manifest that brain dysfunction I talked about as 1 or more of 5 primary complications. And this is very important, folks. I want you to memorize these primary complications. They are intellectual disability, neuromotor dysfunction, seizure or seizure disorders, psychiatric and or behavioral disturbances, we'll call them behavioral disturbances, and sensory impairment. Generally speaking, these are the 5 major functional arenas in which neurodevelopmental disorders will clinically manifest that injury to the brain. This is a really, really important concept, so please remember this. Many, if not most, of the problems and challenges that I and my colleagues at the Lee Specialty Clinic encounter on a daily basis as we try to deliver the standard of care to our patients are derived from 1 or more of these 5 primary complications. And again, I'm going to say it again for you: intellectual disability, neuromotor dysfunction, seizure, behavioral disturbances, and sensory impairment. Now, when it comes to the medical legal issues that attend a patient with a neurodevelopmental disorder, these 2 primary complications that I have highlighted here for you, intellectual disability and behavioral disturbances, these primary complications are the 2 that are of special concern in this evening's lecture, because it is the intellectual disability that severely encumbers a large number of my patients in their ability to understand, let alone consent to dental treatment. It is the intellectual disability that severely encumbers their ability to communicate with me, the existence of pain, the location of pain, the duration of pain, the effect that pain has on their quality of life. They're encumbered in all these areas. And it encumbers their ability to understand the potential consequences of advanced disease. And then we have the behavioral complications, the behavioral disturbances. And these produce the need for various behavior management interventions, which must often be implemented before we can even approach our patients or even lay our hands on them. So these primary complications, these 2 complications, intellectual disability and behavioral disturbances, really can be the source of some significant obstacles to us delivering quality care. And folks, our challenge is to overcome these obstacles. Now, I think this is a very important idea, and so I'm going to say it again. I think I've already said it, but I'm going to say it again. Intellectual disability is not a medical diagnosis, and don't let anyone tell you it is. Intellectual disability is simply one of 5 primary complications associated with multiple and probably thousands of neurodevelopmental disorders. So please remember that. Before we get into the nuts and bolts of the medical issues, I would also want to talk to you for a moment on a couple of other threshold concepts, I call them, that I think should serve to guide our thinking. First, quality patient care in any clinical setting begins with the doctor-patient relationship. And it must begin with a doctor-patient relationship that is built on loyalty and trust. And the patient has to be able to trust their doctor, and you, the doctor, must prove yourself worthy of that trust, and you do so through loyalty to your patients and by serving the interest of your patient before all others. Now, under typical financial pressures of private practice, under professional peer pressure, and under the pressure of time constraints in a busy office, in a busy day, this may not always be an easy thing for you to do. But when you're dealing with patients with intellectual disabilities, you must do it. You must serve the interests of your patients before all others. Remember, please, that nurturing a healthy doctor-patient relationship is not only the right thing to do, it also really puts up a shield of protection for your patient and for you, especially in a medical legal context. I can tell you that any competent medical malpractice attorney would tell you that the single most important component in protecting a dentist or a physician from the threat of malpractice litigation is the establishment and the maintenance of a healthy doctor-patient relationship with all of your patients. If a patient with a neurodevelopmental disorder manifests significant intellectual disability as that primary complication we talked about of their disorder, I'm going to tell you that your fidelity and your faithfulness to the interests of your patient are going to be tested right out of the gate. And here's one of the reasons why. In the presence of intellectual disability, it's often necessary to bring in a third party to the decision-making process, and therefore into the doctor-patient relationship. The involvement of this third person, no matter how well-intentioned they are, no matter how loving they are, or how supportive this person is, the involvement of this third person necessarily increases the complexity of the doctor-patient relationship and the entire patient care process. Those of you who are married, those of you who are listening to me right now and you're married, or those of you who have someone with whom you're in love, you have a significant other that you live with or you cohabitate with. Imagine if you got home tonight and there's a third person there at your house or your apartment, and they're just there waiting for you. And when you get there, this person is like the kindest, sweetest person you'd ever want to meet. They really care about your spouse, and they have absolutely no interest in taking your place as a husband or as a wife. They're just there for the benefit of your spouse, and they're going to be there with you, with the two of you, forever, into perpetuity. Do you think that the presence of this third person would change the nature of your relationship with your spouse? Of course it would. And so it is with the doctor-patient relationship. The introduction of this third person statistically increases the likelihood that someone's interests other than the patient's interests are going to be attended to. So in these situations, I'm telling you, you're going to have to be really vigilant and really protective of the patient's interests. Having said that, let's remember that there is a reason why this third party has been brought into the picture, and that's because the patient with significant intellectual disability is not always able to make informed decisions regarding his or her care, sometimes some very important decisions. But please always remember, as difficult as it is, with the complications that come along with the introduction of the caregiver or the guardian or the family member, that third person that complicates the doctor-patient relationship, remember to serve the interests of your patients first. Part of living up to our responsibility to our patients with IDD is to make certain that we have a little bit of sophistication and knowledge in these concepts, and that we're meticulous in establishing maybe some standards and some protocols in these three important arenas, and they are informed consent, guardianship, and medical immobilization. And these will be the ideas or the arenas that we're going to spend our time on tonight. Informed consent, guardianship, and medical immobilization. Let's begin with a discussion of consent, and more specifically, informed consent. The first legal opinion involving the issue of informed consent that I have been able to find in the research was issued in 1914 by New York State Supreme Court Justice Benjamin Cardozo. He has an incredible biography, and I would encourage all of you to look him up and read about him. Really an interesting American life. But in a case that he adjudicated entitled Schlöendorff versus Society of New York Hospital, in this case, the plaintiff was a tentatively diagnosed, emphasis on tentatively diagnosed, fibroid tumor case. And the consulting surgeon that the generalist brought in advised the two of them that he could not make a more definitive diagnosis unless he could put the patient do an examination with the patient under ether anesthesia. Now, the patient refused surgical removal of this fibroid, but she did acquiesce to further examination under anesthesia. And while she was under the anesthetic, the surgeon, against her wishes, moved forward and surgically removed the fibroid. Well, as things would have it, the patient developed subsequently a gangrenous infection, and then she ended up suing the hospital and the physicians. And the case was litigated in her favor. And in his opinion, Justice Cardozo said, and this is a quote, "Every human being of adult years and sound mind has a right to determine what shall be done with his own body, and a surgeon who performs an operation without his patient consent commits an assault." So that was one decision, and the issue of informed consent really continued to be litigated over the coming decades in multiple cases. And there were other arenas in which the ideas of informed consent and duty to inform and those kinds of concepts were discussed and played out. Certainly after the end of World War II, in the wake of the atrocities that were discovered that had been committed by Nazi physicians against the mentally ill and intellectually disabled who were imprisoned in multiple concentration camps, we had the Nuremberg trials, which produced in 1947 the Nuremberg Code. And the Nuremberg Code was published and disseminated throughout the world, and it provided nations with a set of internationally recognized principles intended to guide the humane treatment of patients. It also included, it's noteworthy, a discussion of the need to obtain the consent of the patient. Later on, in the late 80s, there was a case called Randall versus the United States, and it clearly addressed the duty of healthcare providers to inform their patients of treatment alternatives. This was a 1987 case in which a woman named Jacqueline Randall, who was pregnant and who also suffered with genital human papillomavirus. And Jacqueline gave birth to a young baby named Kimberly, and the delivery was vaginal delivery. And of course, the daughter contracted HPV, and her daughter would, beginning in infancy and moving into childhood, undergo multiple surgeries to remove these persistent growths in her oropharynx and her esophagus. Needless to say, this cost a lot of money and suffering, and so Ms. Randall sued Walter Reed Hospital and the physicians there for failing to inform her that her daughter could have been spared contracting this disease had she simply been delivered by cesarean section. Obviously, this case was decided in her favor, and it established what is known now as the duty to inform. So today, it's fair to say, I think, that legal precedent has clearly established that we, the physicians and the dentists, are the ones who bear the burden of seeking consent from our patients. It is important to note, however, I think, that the manner of obtaining informed consent is generally left up to us, to the providers or the practitioners and our medical and dental staff. Statutes in most states across the country will rarely specify the manner in which you need to obtain informed consent, but it must be obtained, and obviously it must be documented. I doubt that anyone would disagree that if a patient is capable of making his or her own treatment decisions, then he or she should be included in the decision-making process, and he or she should be the party from whom consent is obtained. To my way of thinking, that's just kind of common sense. But if the patient is intellectually disabled, things get a little bit more complicated. And these are the questions, in my opinion, that you need to ask as you go about obtaining informed consent, and more importantly, as you go about determining from whom you will obtain the informed consent. The first thing that you need to determine is whether or not the patient is of legal age. Are they considered an adult in your state? In the majority of states in this country, the age at which a person has the legal rights and responsibilities of an adult is the age of 18. And this is kind of crazy, but it's true. Regardless of their level of cognitive function, unless they have been adjudicated as incompetent in a court of law, and unless a person who has reached, let me say it this way, I'm sorry. And regardless of their cognitive function, unless they've been adjudicated as incompetent in a court of law, a person who has reached the age of 18 is legally entitled to make decisions for themselves. And that reality can cause a lot of trouble for dentists and physicians around the country. And here's why. Because we cannot, in any meaningful context, obtain truly informed consent from someone who has significant intellectual disability. The clinician who is caring for a patient with an intellectual disability who has reached legal age but who has not been adjudicated incompetent is really between a rock and a hard place, because legally that patient could scribble an X on a piece of paper having nothing, no idea what he or she was doing. And in most states, that's kind of acceptable because they have that right to do that legally. I have been told this by state directors of guardianship entities. But the problem is we're against the rock and the hard place because we have a statutory responsibility to obtain informed consent. So the next question that needs to be asked, if this person is of legal age, is, does this patient have decisional capacity? And we're going to talk a little bit more about how to establish decisional capacity in just a moment. But for now, let's just ask the question, does the patient have decisional capacity? Now, if you determine that this patient doesn't have decisional capacity, the next question you need to ask is, does this patient have a legal guardian? Has the patient been adjudicated incompetent in a court of law and has a legal guardian been appointed by a court? If the answer to this question is no, the next question is, does the patient have a person who has been appointed as their medical power of attorney? If so, that person can legally make medical and health-related decisions on the patient's behalf, and you can move forward. But if there is no POA, then the next question you need to ask is, does this patient have anyone who is a next of kin that I can contact and speak with? And if the answer to this question is no, the last question is, who in this patient's sphere of existence, who in this patient's life might be interested in their well-being? Asking and obtaining dependable and verifiable answers to this succession of questions is going to be really critical in your decision making as you move forward in your relationship with this patient. So let's go back now to this question that we said was so important. Does the patient have decisional capacity? What exactly is decisional capacity? According to the Stanford Encyclopedia of Philosophy, decisional capacity can be defined as the ability of healthcare subjects to make their own healthcare decisions. So we must ask ourselves, does our intellectually disabled patient have the ability to make important medical decisions? More specifically, does the patient understand basic concepts like choice and cause and effect? This is another important question, folks, and I've asked myself this question numerous times since 1993 in caring for this patient population in multiple situations. I find myself asking this question: would a reasonable person look me in the face and assert that this patient really has the capacity to give informed consent? Let me tell you, I've come across a lot of caregivers, many of whom were not the most sophisticated, and they would say something to me like, oh, Bobby makes all his decisions. He picked out what color we painted his room, and he loves to pick out his clothes. But, you know, if you've got a significantly intellectually disabled patient with cor pulmonale or COPD or a chronic gastric issue that hasn't been diagnosed for decades, there's a big difference between picking out what sweater you're going to wear and making an informed decision about moving forward for a surgical procedure. So I'm talking about the capacity to make important decisions, not what you're going to have on a sandwich or what color you might paint your room. And so this is a logical and reasonable question to ask. Would a reasonable person assert that this patient has the capacity to give informed consent to a medical procedure? And I'll tell you, this question, it's not only logical and reasonable, it has some basis in case law. Indeed, the term reasonable person is a phrase that's frequently used in tort and criminal law to describe that hypothetical person in society who exercises average care, skill, and judgment in conduct, and who can serve as a comparative standard for determining liability. So really, if you're asking this question, you don't have to be hesitant in doing so. And you can be confident that if you can get a truthful answer to this question, you're going to absolutely have something that will carry some weight in a legal proceeding. I would feel comfortable with the majority of patients that I've worked with standing in front of Judge Judy and saying, no reasonable person would ever assert that this patient had the cognitive function to give me meaningful informed consent. Now, establishing a way to objectify and support that assertion is very important. And here's how you do that. You say to the patient, is it daytime or nighttime outside? Who's the president of the United States? Why are you here today? And this is a really important one. If I put my finger in a flame, what's going to happen? And so if you ask these questions, you should, and you get answers, you should accurately document the patient's ability or their inability to answer these questions. And that's going to be a powerful piece of information to be entering into the patient record, I guarantee you. Now, I've always believed that if it is evident to a reasonable person, that hypothetical reasonable person, if it's evident to a reasonable person that the patient doesn't have the cognitive capacity to give meaningful and truly informed consent or to participate in the decision-making process in a meaningful way, that we really do a grave service to these folks if we pretend that they do have that capacity. I also believe that if it's clear to me that my patient does not have the cognitive ability to make informed decisions about some really important stuff, it's my responsibility, because I'm their advocate. I'm just not their doc, I'm their advocate. And it's my responsibility to try to find someone who will help them with that decision-making process. I'm sure that anyone who's joined us this evening would probably agree with me that obtaining consent from a neurotypical patient, a patient without an intellectual disability, is really often not all that complicated. And in fact, case law across this country defines a kind of consent known as implied consent, which is a consent that we give when we go to our physicians and our dentists simply by virtue of our actions and our behaviors. And here's how it works. I have a toothache. I want to go to the dentist. I go to a dentist that a buddy of mine refers me to. He says he's really good. I get in my car, I drive to the office, I sit in the waiting room, and I read Sports Illustrated until the young assistant comes to the door and calls my name, and I walk back down the hall, and I hop in the chair, and I lean my head back, and I open my mouth, much like the gentleman that you see here. By doing all these things, by virtue of my actions, even without speaking my consent or writing my consent, I have given my doctor implied consent. This is what implied consent is. I'm of sound mind. Now, some of you may disagree with that, but I think I'm of sound mind. We voluntarily, go to our doctor's offices. We do all these things that a typical dental patient would do. That's implied consent. But when you have a patient with a significant intellectual disability and disadvantage, and they present for treatment in your clinic or your office, implied consent goes out the window. There is no such thing as implied consent for a patient with a significant intellectual disability. And this is really important. If you seat a patient with a significant intellectual impairment or disability in your dental chair, and you begin placing your hands on them without first obtaining a consent to do so from someone of sound mind, someone who has decisional capacity, in most states in the United States, you're going to be liable to be charged with battery. And this is why at our clinic, the Lee Specialty Clinic, and in any special needs clinic I've worked in, and I worked in clinics in Illinois and Florida and Iowa and here in Kentucky. Anywhere I've ever worked, we've always obtained a guardian's or a medical POA signature on a form known as the Consent to Examine and Treat form. We'll talk about that a little bit later too. And we get that signature before we even take the patient out of the waiting room and back to the operatory and seat them in the chair for their initial examination. Remember, the doctor-patient relationship begins at the point that the patient sits in your chair. That's an important thing to remember. A little bit more on that later. Now, if you remember nothing else from this evening's lecture, I would want you to please remember this. And I'm sure you've probably all seen this and you probably all know this, but I have to say it. Obtaining meaningful informed consent means that you have explained the risks and benefits of receiving treatment in language that the patient or if they're intellectually disabled, their guardian or their POA can understand. That you have explained the risks and benefits of not receiving treatment in language that the patient or their guardian or their POA can understand, and that you have given the patient or the guardian or POA the opportunity to ask questions and have those questions answered in language that the patient or the guardian or the POA understands. And once you've done all these things, you must document that you have done them. If it's not written in the chart, it didn't happen. Now, does informed consent need to be obtained in a formal or previously prepared consent form or document? I think I already answered that question, but we're going to answer it again. The answer is no, absolutely not. But I do want to make two really important points here. Number one, get consent that is appropriate for the clinical situation. And it does not need to be an assigned formal consent form, although I would strongly urge that you would do that. That's the preferable way to get consent, to have preformed consent forms that you've had a med mal attorney review for you and tell you that these are safe and protected. That's the best way to do it. But you don't have to do it that way. You just have to get consent. Number two, when you get consent, write it down, document it. If you're getting consent from a patient verbally, I would write a note like this in the chart. It would say something like, consent was obtained from patient's guardian to examine and treat the patient. Risks and benefits of the examination and treatment were explained to the patient's guardian in language they understand. Risks and benefits of not receiving examination and treatment were explained to the patient's guardian. And guardian was given an opportunity to ask questions, and her questions were answered to her satisfaction in language that she obviously understood. That's a pretty good note, in my opinion. Now, this is an extremely, extremely important point, and you have my wife to thank for this. I added this slide this year at my wife's insistence because one of our AADMD developmental dentistry residents had this very issue come up last year, and it really did create a very difficult situation for her. So please remember this, because it could save your license. When you're getting verbal consent from a guardian in person, face to face, have a witness there, and preferably it would be a staff person, someone on your staff. Have them present to corroborate that the consent was in fact given verbally. If you're obtaining verbal consent from a guardian over the telephone, after you've been given consent verbally, hand the telephone to a second person, again, preferably a staff person, and have the guardian repeat that consent to that second person. And then both of you go to the chart, the doctor and the staff person, and write a separate note documenting that the verbal consent was given. And again, if it's not in the chart, it didn't happen. This can keep you out of a lot of trouble. Now, the consent forms that are used in a developmental dentistry or a special needs dentistry clinic are a little different than those you're going to find in a typical suburban dental practice. First of all, we've talked about the consent to examine and treat form. We touched on that a little earlier. This consent to examine and treat form simply allows you to seat and actually touch the patient. Remember, in the presence of significant intellectual disability, there is no such thing as implied consent. So you have to get consent to examine and treat them in the waiting room before you take them back. Second is the consent to utilize medical immobilization. Medical immobilization, as I'm sure you know, is the tour de jour. Is that what is the term? It's the politically correct term for restraint. This is a consent form that you're never going to see in Jennifer Aniston's cosmetic dentistry office in Malibu. You can trust me on that. We probably also ought to have proper consent in place before we restrain a patient, don't you think? So that's a really, really important consent form to get. The third one is the consent for deep sedation or general anesthesia. And my thought is that before we start an IV and start running in propofol, or before we take the patient to the operating room and put them under general anesthesia and intubate them nasotracheally, we probably ought to have a consent to do that as well. And finally, we have the consent for surgical procedure, which is really not any different than the surgical consent form you would see in any dentist's office who does oral surgery like I do, or any oral surgeon's practice. And remember that consent can be withdrawn at any time. It is not in any way binding into perpetuity. And this idea is known as the right to refuse. All of this leads us to a discussion of guardianship. What is guardianship? What is a guardian? Well, here's what you would find if you went online and you performed a simple search for the definition of guardian. A guardian is defined by the Electric Law Library as a person or an institution named in a will or a temporary guardianship who is responsible for the care of minor children, or a person assigned by the court to take care of minor children, or, and here's our folks, incompetent adults. A guardian is also sometimes called a conservator. Now, there are different forms of guardianship, as you might guess, in different states, but suffice it to say that forms of guardianship range from time-specific, temporary, and limited guardianship to full guardianship or full co-guardianship. In most states, what are known as healthcare proxy laws, and these are state laws, not federal laws, laws that are known as healthcare proxy laws allow another person to step in and make decisions for legally incompetent persons. This is where the different types of guardianship come in. But remember, generally speaking, and we'll talk about some exceptions to this idea, but generally speaking, guardianship status needs to be determined before the course of treatment begins. And remember, even if you were only able to get what's known as a medical power of attorney to agree to the treatment and get that POA in place, that alone will provide you significant medical legal protection until the guardianship process can be completed as you move forward with the patient's treatment, even if it's routine treatment. If you've got a medical POA available to you and they have their documentation in place, you're covered pretty well. A medical POA is just basically a legal document which gives a third party the ability to make medical decisions for an intellectually disabled patient. And I have to tell you, sometimes they stay in place for years and years and years, and people never get a guardianship hearing. My opinion, and the opinion of our very brilliant med-mal lawyer, is that every parent with an intellectually disabled child, when that child reaches the age of adulthood, needs to pursue guardianship. And she believes that if they don't do that, they really are practicing neglect. There is in this country, in the practice of developmental medicine and dentistry, what I call the guardianship conundrum. And I really would be derelict in discussing guardianship tonight if I didn't talk about this. It's called, I call it the guardianship conundrum. In communities and states all across this country, there are thousands of individuals who have significant intellectual disability and who are in a medical and legal guardianship limbo with no one of sound mind to make safe and legal decisions for them. There are two major reasons why this is so. First, many families don't want to surrender their intellectually disabled loved ones' guardianship to the state or to any other entity because of all that they think that would represent. In short, they just can't live with the idea of giving Johnny away to the government. At the same time, they don't want to take on for themselves what they see as the immense responsibility of full legal guardianship because of all that that would entail as they see it. The paperwork, the mounds of paperwork, the Department of Social Services, bureaucrats making unannounced checkup visits on them. They imagine all of that. And they also imagine erroneously that if they become their loved one's guardian, they then will be legally responsible for all of the money that must be paid for healthcare services, and that's absolutely not true. In most states in the United States, if a patient is adjudicated incompetent, that patient is instantly able to go on public assistance, and that will shield the guardian from these costs. But these are things that people believe. And so again, for these reasons, we have in every state in America literally thousands of individuals with cognitive impairment who are in what I call this medical and legal guardianship limbo. And it puts everybody, the patient and the doctor, especially the doctor, in a very difficult position. And when you're really in a difficult position is when an emergency or an urgent issue comes up. In a case of an urgent or emergent situation, if you have, in the manner that I've talked about, if you have established that the patient is obviously unable to give you truly informed consent. And I think if you look at this patient's mouth, you might say to yourself, there's some urgent stuff going on here that really needs to be addressed. But if you have established that this patient, the guy we're looking at, obviously can't give you truly informed consent, and again, that means that that reasonable person would understand that they don't have decisional capacity. And if no guardian is available to you, no guardian has been designated, and if no relative of this gentleman can be contacted or even exists, when all the cards like these are seemingly stacked against the patient and you, what do you do? Well, this is what you do. In an emergency situation, if the patient is obviously unable to give informed consent, and if no guardian has been designated by a court of law, and of course, if the patient is of legal age, and if you've made a reasonable effort to contact the next of kin because you don't have a guardian, you don't have a POA, you don't have decisional capacity, the next thing you got to do is try to find a next of kin. If there's no relative or family member available to give you consent, here's what you do, folks. You render the emergency treatment, you put your patient's interests first, and you treat the emergent issue. Then, after you treat the patient, you immediately call Adult Protective Services. These folks have offices in practically every major city, and in some smaller ones. You contact Adult Protective Services and you tell them that you have treated this patient. And you let APS, Adult Protective Services, representatives know that you have found a potential self-neglect situation. This is called self-neglect. And if a relative does exist, if there is a relative out there before you treat this patient, you want to make a reasonable effort to contact that person. But one phone call, folks, is considered a reasonable effort. Okay, so if you make one phone call in an emergent situation to try and contact a relative, a next of kin, and you can't reach them, you've made a reasonable effort to do so. And you can feel confident proceeding with treatment. Now, you need to document everything that you have done. And documenting everything you have done, every phone call, every question you've asked, everything that you have done will demonstrate that you've practiced due diligence. And you will have, in fact, gone above and beyond what most clinicians would have done, which is to turn this poor soul away and let them go back to no treatment, no advocacy, no compassion, and no relief from their pain. So remember, if you do these things, you will be on very solid ground in a medical legal context, and more importantly, you will have done a great service for your patient. So here's an emergent situation. Would you say that this is an emergent situation? I think so. In my opinion, it is without question an emergent situation. This patient's radiographic panel demonstrates at least 14 separate periapical lesions. This is one of my patients. Many of these lesions could actually, some of them may be granulomas that have quieted down, but many of them could be active periapical abscesses, and any one of those could seed a potentially life-threatening systemic bacteremia. Not a good thing. This patient is, as my friend the oral surgeon said, essentially a walking time bomb. In this case, I definitely would go through all the steps that we've discussed in an attempt to obtain informed consent from an adult of sound mind. But if this patient was of legal age and the patient was obviously incapable of giving me truly informed consent, he did not have decisional capacity, and even if I were unable to locate a next of kin or someone who had interest in a patient's well-being, I would have proceeded, and I did proceed, with a full mouth serial extraction of these diseased teeth under local anesthesia in one setting. And I followed this case with a 5-day course of 10 VK, 500 milligrams POQID, and I obviously brought him back a week later to remove any sutures that had been put in and to check his condition. But when I'd done all that, I would contact APS and I would advise them that I had a patient in a self-neglect situation. And I did do that, and I asked them to immediately move on establishing emergency guardianship for this patient moving forward. So I have to tell you, if any of you have a weak stomach, this would be a good time to step away from your laptops. Is this an emergent situation? Well, this is one of the saddest cases that I have ever encountered. The police were called to this young man's home by neighbors who hadn't seen him in his wheelchair in the yard in months. He lived with his brother. And these neighbors were concerned for his well-being. So they called the police, and the police came to the patient's home. And when the authorities arrived at the front door of his brother's house, he lived with his brother, the patient's brother came to the front door with an angry look on his face. He pushed the patient in the wheelchair out the front door onto the front steps in his wheelchair. And then he told the police, and I quote, the cop told me this, "You can have him," unquote. And then he slammed the door in the policeman's face. The patient's condition really could only be described as ghastly. He was sitting in his wheelchair in his own dried feces. The officer said that he was literally stuck to his wheelchair in dried feces, and he obviously had been that way for some time. His fingernails had grown so long that they curled around to the underside of his palms. His toenails had grown so long that they curled around to the underside of the plantar surfaces of his feet. And this is where it gets really sad, folks. He had bilateral hip fractures. Imagine the pain that this poor guy must have been in. The police obviously called an ambulance immediately, and the patient was immediately taken to the emergency room by EMS. Those of you who have been in healthcare for a long time might know what I mean when I say that he was given a betadine bath. They washed this gentleman from head to toe with betadine before they would even take him into the operating room. His hip fractures were surgically repaired, and as you probably know, hip surgeries go pretty well these days. And shortly, I think he was only in the hospital for 4 days, but shortly after his discharge from the hospital, they brought him right to my clinic. This poor guy was clearly incapable of giving informed consent. His brother, remember the brother, and I use that term loosely, was the only family member alive, and he certainly wasn't answering his telephone. Every single tooth in this patient's mouth exhibited a +3 mobility or greater. A purulent exudate was welling from the sulcus of virtually every single tooth in his mouth. You can see it in the image. And for those of you who don't know what purulent exudate is, it's pus. This patient had pus surrounding the sulcus, the gum pocket of every single tooth. This is another patient who was a time bomb. He was a systemic bacteremia waiting to happen. So in addition to the threat posed by this severe periodontal infection, he could have gotten a systemic bacteremia. But in addition to that, I was concerned about the real possibility that these teeth would spontaneously dislodge and that he would aspirate a tooth into his airway, and we would then be looking for a foreign body aspiration and really a pretty guaranteed lung infection. So this was one case that we did not use the Molt mouth prop. I barely breathed as I was working around this gentleman. No one who had anything to do with him, no one that transported him to me, no one that had any information about his case, no one that had spoken to the brother, nobody had the strength of character to step forward and give me consent. I probably called around town for a half an hour while this guy is lying in my chair, trying to find somebody brave enough to give me consent. I was finally able to contact a wonderful man. His name is Bob Napalili, and there's a place for him in heaven. He's a crisis unit director at a local public hospital, and he was going to be in on the case, and heroically he agreed to give me consent and to advocate with me on this patient's behalf. This crisis unit director also agreed to move forward with getting a hold of adult protective services so that I could be freed up to move forward with expeditious treatment of this case. So under local anesthesia, I went ahead and performed a full mouth serial extraction of his remaining teeth. Unbelievably, I was able to remove his maxillary anterior teeth, the teeth you see there at the front of the image, with my fingers. It took no elevators or forceps. I took the majority of those anterior teeth out with my fingers. That's why I was so concerned about aspirating a really diseased and contaminated foreign body into his lungs. Well, the story has a happy ending. We got all of his teeth out. We got some nice clean suturing done. We cleaned up his entire mouth and disinfected it. And I always suture my extractions closed because my patients don't have the cognitive capacity to bite down on gauze. So we sutured him with a 2-0 silk suture throughout both dentitions. He returned a week later, folks, and he was up, walking around, no longer in the wheelchair, totally healed from his hip surgery, clean as a whistle and smiling. And I'll tell you, this is a case that I'm never going to forget. How about this case? Is this an emergent case? Well, notice the notched incisors. And those of you who are dentists, look a little closely in the lower left quadrant. You can just barely see what's left of a mulberry molar. And I know you're all waving your hands in the air because you know what this patient has. He has congenital syphilis. He was also severely intellectually disabled. Clearly incapable of giving me informed consent. And, you know, things are never easy in a developmental dentistry clinic. Complicating this even already complicated situation was the fact that his mother, who also had syphilis, was also intellectually disabled. So in this case, I improvised a bit. I obtained consent from his mother, who was, after all, his next of kin. But I made a clinical judgment, an executive judgment, you might say. His mother was highly functional, higher functioning, I'll say that. It was my opinion that she had something close to decisional capacity, and I really needed to do something for this poor kid. He was in a lot of pain. He was just emaciated. Eating was very uncomfortable, so he wasn't doing much of it. At any rate, I got mother's permission, and it was recorded properly, and I proceeded to remove all the teeth. We didn't do a full mouth extraction on this guy because I really needed to clean up all of this infection and this inflammation and really see what we were looking at. But I knew that there were, we did radiographs. I knew there were teeth that were potential sources of systemic bacteremia. So we addressed those teeth in what's known in the industry as worst first. I placed him on Paradex. I put him on oral antibiotics. I extracted the teeth that were obviously abscessed on X-ray, and I scheduled him for a further evaluation and treatment down the road. And in the interim, what did I do? I did what I always do. I contacted Adult Protective Services, and I said, look, this is really an untenable situation. The mother, I deemed her competent to give me consent to move forward on this case. This was really an urgent case, but I certainly didn't think that she had any business being his guardian moving forward. So APS quickly came in and established emergency guardianship, and he was able to have his treatment completed expeditiously at our clinic, and he still has a relationship with his mother, so it really has had a very good ending. Now, in all of these cases, I endeavored to give my patients' interests my first thinking. I put my patients' interests at the forefront. In all these cases, there were a lot of unfortunate social circumstances in every one of these cases. I don't think you'd disagree with me on that. But I tried to not let these unfortunate social circumstances get in my way. And I'll tell you why. I didn't want to become the next obstacle in a long line of obstacles to these patients' well-being. I knew that if I didn't take this action, that they would go back to their home, back to their dysfunctional existence, back to their pain, back to their infection, and nothing would ever happen for them. So I rendered the emergency treatment. I took all the steps that I've described to you tonight. I notified APS in all these cases, and in all three cases, I meticulously documented what I had done. And I went home feeling pretty good. So let's get to the really dicey issue of the evening, and that issue is the issue of medical immobilization, or as it's more commonly known in some circles, restraint. Except for the issues of deinstitutionalization and community integration, as it's called, there's probably not an issue that incites more passion and often, in my opinion, more nuttiness and craziness among disabilities advocates than the issue of medical immobilization, or as it's more commonly known, restraint. The issue of restraint is just a very hot political issue in disability advocacy circles. And so this evening, what I would want to do is just define restraint for you, summarize the consensus of the national developmental dentistry experts on the issue of medical immobilization. I'd like to articulate some basic concepts and then establish what I think is a reasonable and straightforward behavior management protocol. By the way, for those of you who don't know, that's Steve Perlman, our dear friend, probably the father of developmental dentistry in the United States. He was Rosemary Kennedy's dentist. He's a dear friend, and we call him Saint Stephen. Okay, so let's begin with the federal government's definition of restraint. Current federal law defines restraint, and I quote, as any manual method, physical or mechanical device, or material, or equipment attached or adjacent to the individual's body, which the individual cannot remove easily and restricts freedom of movement or normal access to one's body. Wouldn't you love to see the bureaucrat that wrote that? That's how the federal government defines restraint. And there are basically two take-home points, I think, that need to be made right now. Number one, this is very important, physical restraint should only be used as a last resort in managing resistive behaviors during medical and dental procedures. And number two, this is, not many people know this, but I'm going to make this point. It's very important. Chemical agents like psychotropic medications in large doses and certainly general anesthesia are definitely a form of restraint. For those folks out there who send all their patients to the operating room for general anesthesia and they claim to be restraint-free, they are living in a dream world. There is such a thing as chemical restraint, and that is general anesthesia, and it is the most aggressive form of behavior management. So I'm going to have to pop that balloon. With respect to what a general protocol should be when utilizing medical immobilization in managing resistive behaviors in intellectually disabled patients and behaviorally challenged patients, here you have the consensus of these three organizations, national organizations. The American Academy of Developmental Medicine and Dentistry, which is the organization I co-founded with Dr. Philip May and Dr. Matt Holder and Dr. Rick Rader and Dr. Steve Perlman. We also have Special Advocates in Dentistry, a wonderful old organization of some very dedicated clinicians, and then a wonderful group that Paul Glassman started called Special Care Dentistry. All three of these organizations, and we have expertise, believe me, we all, for the most part, agree that medical immobilization should only be used when it's absolutely necessary to provide for the safe delivery of dental care. When medical immobilization is utilized, the least restrictive alternative should be selected for use. When medical immobilization is being used, a doctor's order for it should already be in place before it is used, and the doctor and staff need to closely monitor its use during the period of time that it's being implemented. And then the use, the type, the indication for, and the duration of this medical immobilization should all be documented meticulously in the patient's chart. We do all of this at the Lee Specialty Clinic, and we work with a very talented board-certified behavior analyst named Stephen Foreman. This is a very, very important point, and I will defend this until the last day that I'm working and practicing. In most cases, and at the Lee Specialty Clinic, most cases means 98% of the time, for a medically compromised, severely and profoundly cognitively impaired patient, mechanical restraint properly utilized is a far safer method of behavior management than referral to the operating room for general anesthesia. Now, in the United States of America, Dr. Matt Holder has found some numbers that tell us that the referral rate for an intellectually disabled patient to the operating room for comprehensive dentistry under general anesthesia and endotracheal intubation is about 25%. At the Lee Specialty Clinic, our referral rate to the operating room is approximately 2.8 to 3%. For many years, it has hovered right around 2.8 to 3%. That's a hell of a differential there, and we're very proud of these numbers. And the reason our referral rate is so low is because we have a spectacular behavioral team. We have a very, very seasoned and experienced developmental dentistry team, and we can more effectively manage these behaviors in the clinic compassionately and safely than most of our counterparts around the country. Now, these are generally accepted levels of restraint intervention. These are also referred to as the hierarchy of behavior management or behavior management intervention. We start out with the least invasive and end up with the most invasive. We begin with deflection of arm movements gently away from the operating area. Then we move up to hand holding, gentle hand holding, as you see here. We also have wrist wraps that we can use. I haven't shown you them, but I can describe them for you. They're basically soft vinyl wrist wraps, straps with Velcro. where you can wrap the patient's wrists gently and then secure their wrists to a lap belt or a safety belt, much like you would see on a surgical gurney. Then comes the papoose board. The papoose board, you're probably all aware, is a canvas and Velcro affair that can be wrapped around the patient's entire body and stabilize them if they're resisting treatment. Steve Perlman was shown in that early photograph that I showed you of him actually placing a patient in a papoose board. Papoose boards can be used on to put pressure on autistic patients and calm them. We've had great success with papoose boards. Sometimes we'll put a patient in a papoose board and even lay a weighted blanket on them and really get them calm. I rarely see a patient screaming and yelling in a papoose board. They're typically calm and very docile. Then we have oral sedation, which I don't like at all. I spent probably 45 minutes on the telephone one afternoon talking with Stanley Malamed, who is, I think he's at USC, and he is clearly the godfather of pain control and sedation, and he and I are totally on the same page. Oral sedation is a very clumsy method of significantly subduing a patient who's resistive in their behaviors. You can't titrate oral sedation very rarely. If a patient goes deeper than you want and their breathing slows, you have virtually no options. You don't have an IV in place. You don't have the airway protected, so you can't ventilate or reverse the medication. It's just a very dangerous route of administration, and we shy away from it. If we can't safely deliver care in the papoose board, and sometimes we can't, we go straight to the operating room and do a comprehensive dentistry under general anesthesia and nasotracheal intubation. So in summary, what I'd like to leave you with tonight, folks, and again, thank you for joining me and thank you for your patience. With respect to the three major medical legal arenas that we've discussed and kind of walked around in this evening, and that is informed consent, guardianship, and medical immobilization, I want you to remember these rules of the road, because these are, what are these? 1, 2, 3, 4, 5, 6, what are these? 7 commandments? These are the 7 commandments. Find out if the patient is of legal age. If the patient is of legal age and they have decisional capacity and they can give you meaningful consent, then surely that's a wonderful thing. But if they don't have decisional capacity, you're making a grave mistake if you try to pretend that they do. If they clearly do not have decisional capacity, find out if they've been adjudicated incompetent in a court of law and had a guardian appointed, and if that has not happened, find out if a medical POA has been appointed. Once these issues of guardianship have been resolved, be certain to procure all the consents, or excuse me, all the consents that are indicated, and procure them at the proper time. Make certain that the consent to examine and treat form is in place, again, before you even take the patient back. It's also wise, really, to have the conversation about medical immobilization and restraint, to have that conversation and that discussion out of the way before you even take the patient back. And don't be ashamed to talk about it. It's an issue that you're going to have to talk about with the families and the caregivers. Have that conversation out of the way and have the consent to utilize medical immobilization, if necessary, in place before you even take the patient back. If medical immobilization is required to safely treat that patient and you have consent to do so, be sure to implement the least restrictive method necessary to render that treatment safely. In all of these arenas, consent, guardianship, and medical immobilization, meticulous documentation is really, really important. And finally, and most importantly, as you navigate these medical and legal issues, this landscape can get complicated. So as you navigate these medical and legal issues, and as you unravel this complicated ball of string and interface with the patient and the guardian and the caregiver, make sure that you keep the patient at the center of everything that you do. If you start at the patient and work out in everything you do, you'll have a concentric logic that will really guide you. In doing the right thing. And I'm telling you, the best advice that any mentor that I could give anybody, or any mentor could give anyone, or any clinician, I will give you again tonight, and that is serve your patient's interests first. Thanks to all of you for joining with me tonight, and thanks to listening to me rant and rave. If you have any questions, I will be happy to take them. Again, this is my mug and this is my email address. Thanks for listening tonight. And Shannon, if there are questions, I'll be happy to take them.
Yes, there I believe is one question, one comment.
Okay.
How was he able to have hip surgery without consent, and why were the teeth not extracted during the hip surgery?
I'm sorry. Say that a little more slowly so I can understand. Why? First of all, which patient are we talking about?
The one that you said that had the brother who neglected him.
Basically disowned him. Yeah. And what is the question?
How was he able to have hip surgery without consent, and why were the teeth not extracted during the hip surgery?
Because bilateral. Why were the teeth not extracted when he was under anesthesia? Probably because the surgeon that was on call or attending the case was not sophisticated enough to look in the patient's mouth and to make the judgment to have that taken care of. This case came into the crisis team very rapidly. He came in on a weekend, and so we were all scrambling to do all this stuff on a weekend. The surgeon, I'm confident, did not have consent from anybody to repair his hips, but that's an emergency. And believe me, that surgeon was well within his right to do what he did. And the reality is that we, by establishing emergency guardianship, if I were that hip surgeon, I would have done the same thing. Now there's some out there who wouldn't, and that's fine, but I would have. That patient was in dire shape. He was in great pain. And again, you have a choice of becoming an obstacle or becoming a solution, removing an obstacle. And the surgeon, I'm guessing, I don't know for certain, I'm guessing he did not have consent. Maybe there was somebody there who said, okay, I'll give you consent. I'll take responsibility. But I doubt it. I couldn't find anybody but Mr. Napoli who was willing, as a crisis unit director, to take that responsibility. And if I hadn't have found anybody, I would have gone ahead and performed the serial extraction, cleaned his mouth up, sutured him together, put him on antibiotics, contacted Adult Protective Services, and I would do it again. I mean, I think it's the right thing to do.
Yeah. Okay, so the second question, we have several questions.
Pardon me?
We have several questions, so we'll just go through them. The ACLU has advocated for supported decision-making in place of guardianship for people with disabilities.
Wonderful idea.
Do you see a role for supported decision-making?
There's no question about it. As a matter of fact, the Elite Specialty Clinic has joined with the Council on Developmental Disabilities, which is the oldest advocacy organization for people with IDD in this state. And we actually put together a monograph. We haven't published it yet, but we did a study in our clinic of a fairly large group of patients utilizing supported decision making. Some of the best scientific writing I ever did, I wrote the intro for this article. And yeah, we're definitely into supported decision making. It is a great idea. I'm even meeting in the next couple of days with a man who's in the guardianship office here in the Commonwealth of Kentucky. And he knows because he's in the trenches with the rest of us. He knows what a huge issue this is, these patients who are abandoned. I'm telling you, my med mal lawyer is like the best. And she says if parents don't attend to the issue of guardianship when their IDD kids reach legal age, they are committing neglect. It's just a neglectful thing. And it puts the doctors in a horrible situation. A horrible situation.
Okay. Next question. If a patient does not communicate verbally, do you assume they have capacity? Do not have capacity?
Well, that's kind of a sticky question. We have patients who can't communicate verbally, but they can communicate with assistive technology. So, sure, if I've got a patient, you got to look at somebody like, if the question is the patient verbal? If the patient's not verbal, do you consider them not having decisional capacity? No, I would refer you to who's the guy, the astrophysicist with Lou Gehrig's disease who passed away this year? Stephen Hawking. He had to blow into a thing, some assistive technology device so he could communicate with his astrophysics students at Oxford, and he certainly had decisional capacity, but he couldn't vocalize, not very effectively in any way. So no, it's a question of, can the patient communicate? And do they have, because Stephen Hawking's had brain function. He didn't have a dysfunctional brain. He had a dysfunctional body. And it interfered with him being able to speak. So the critical issue is, does the patient have decisional capacity? And we have plenty of patients who can't speak, but who we communicate with communication boards, autistic patients that talk to us on their iPads. So that's a very good question. But no, decisional capacity is a function of cognitive function, not speech. Did I answer that well?
Yes. You did. Here's a comment. Thank you for stating that anesthesia is a form of restraint. My daughter has profound IDD. I bring my own papoose, or how do you pronounce that?
Papoose board. Papoose.
Board. To the appointment to have her teeth cleaned. It's really hard, and I often feel guilty. In the past, when she has been under general anesthesia, she ends up being admitted for a few days. There's always a complication.
Of course there is. Now, believe me, and listen, if you're still out there listening, ma'am, God bless you. And feel free to reach out to me. We'll give you whatever support you need that we can. And God bless you for bringing your papoose board to the doctor's office. I will tell you, and I don't want to step on any toes, but the real frothy-mouthed advocates who advocate against the papoose boards are frequently people who aren't parents, who don't have any experience as a parent of a child with these challenging behaviors, and they're oftentimes not clinicians. Now, there are some clinicians who vehemently rally against the papoose board. But I will tell you, my clinic sees more people with intellectual and developmental disabilities any place in the country. Our clinic is unlike any clinic in the country. We delivered 14,000 patient visits last year. People travel sometimes 5 hours each way to come to our clinic. We have people coming from out of state to get interdisciplinary workups. I'm not bragging, I'm just telling you, I got a great team. We're the experts. And Steve Perlman was President Kennedy's dentist, or President Kennedy's sister's dentist. Steve's one of my best buddies. Steve said, if you take my papoose board away, I'm hanging up my lab coat. And there have been some unfortunate articles written by organizations that I don't think have the expertise that the AADMD has. The papoose board is a very, very useful tool. It's not the only tool, but for a specific kind of patient, it's just a must. It's an accoutrement. My eldest son is a pediatric emergency room doctor. He has a child come in with an inch-long laceration on their forehead. and he's got to put 6 or 7 stitches in that kid's head, and the kid's 3 years old. What's he going to do? Is he going to take that kid back, put him under general anesthesia, and intubate him, and knock out his drive to breathe, and ventilate him mechanically to put in 6 stitches? No, he's going to put the child in a papoose wrap, and he's going to gently administer a local anesthetic, and the kid may cry, but the kid is being treated more compassionately than being taken back to the OR and being put under general anesthesia. This is just an issue of common sense, and these are questions that need to be decided by clinicians and parents working together and talking together. That's what I think. And God bless you if you're still out there listening for doing what you do for your child.
Next question. I think this is the final question. What are your thoughts on nitrous oxide?
Nitrous oxide, nitrous oxide in some patients is effective. We have it in our clinic, and we're trained in it, but we don't use it very often, and here's why. Nitrous oxide is like, for example, if my wife was going to go to the dentist, who's a dental folk, nitrous oxide would be great because my wife suffers with anxiety, dental anxiety, and anxiolytics like benzodiazepines are very effective in patients, neurotypical patients who really have dental anxiety. You really can calm a person's anxiety with benzodiazepines and with nitrous oxide. Now, having said that, the majority of my patients don't actually have anxiety. They have what's known as agitation. A child, an adult who comes to my clinic who has the cognitive level of, say, a 2-year-old, when he gets resistive and starts beating on my arms to get the instruments away from him, that is not unlike the 2-year-old child that goes into the emergency room and the ER doctor tries to look in their ear with an otoscope and the kid starts yelling and batting the doctor's hands away. That is not anxiety. You'll never be successful giving that child an anxiolytic and then expecting him to cooperate because it's agitation. If you study people who treat geriatric patients, they will tell you in geriatric dementia, do not use benzodiazepines because they're anxiolytics and you're not dealing with anxiety. You're dealing with agitation in dementia and oftentimes in intellectual disability. Now we have high functioning patients who are experiencing absolutely true anxiety. And for those patients, my high-functioning patients with cerebral palsy, these beautiful ladies who come in, these 60, 70-year-old ladies who've lived a long life and who are very proud that, they're cognitively totally intact. And they're proud, they put on their makeup and they dress up nice so they look good to come into the clinic. I'll use benzodiazepines on them in a heartbeat because they're high-functioning. They have the capacity to experience anxiety. And I'm not saying that people who have a lower level of intellectual functioning, we have some patients who are probably at a 5-year-old level who weigh about 300 pounds, and 1 or 2 of them we really believe are exhibiting signs of anxiety. So the question is, if you're going to use nitrous or benzodiazepines, make sure that you're dealing with anxiety. But otherwise, those interventions are not going to work. And as a matter of fact, anecdotal evidence among my colleagues is that oftentimes lorazepam or Valium will actually exacerbate and worsen the restrictive or resistive behaviors. So I hope I've answered that question intelligently.
That was amazing. Thank you so much for presenting this. I learned personally a lot.
I hope I didn't bore anybody.
No, it sounds like it's very interesting to a lot of people. I think we will eventually put your video or this talk on YouTube.
Okay.
Just have to get somebody,
Okay.
if you would like to. I mean, it's all up
You
to
have
you.
my permission. I own all this material. I own all of these images. I either took them and got permission to use them, or I purchased them from folks. And so all of the imagery in this production is owned and it's copyrighted and all of that. So.
Okay.
And I'd be happy to present again on. I'll send you my syllabus, and you can look over different, products that I have. I've got about probably a 10 lecture course.
That would be amazing. I would love it.
Yeah, and I meant what I said. Come and visit us, Shannon.
I definitely will. I promise. I would love to.
Yeah, come and spend a week with us.
Love it. All right. Well, I guess there's no more questions, and we'll send out your email to the people who attended, if that's all right, if they have any other.
I would love to hear from everybody, and thank you, everybody. I appreciate your signing up and joining us. Thanks, everybody. Happy holidays to everybody.
Likewise.
All right. Take care.
You.
Good night.